Good morning. We're going to talk now about the clinical pharmacology of newer reverse transcriptase inhibitors. And we'll start with Islatrovir, the NRTTI translocation inhibitor. As you just heard from Professor Perno, this drug has a unique mechanism of action amongst the nucleoside reverse transcriptase inhibitors in that it contains a 3' hydroxyl in the ribose ring, which allows it to be incorporated into the growing RNA-DNA chain, where it then causes chain termination. Islatrovir, previously known as EFDA, has a very long half-life, which allows it to be used in a variety of ways in clinical studies and eventual clinical applications. It's also an exceedingly potent antiretroviral drug, and it is being developed in both a low-dose oral and parenteral formulations. This is just a reminder that this drug has significant anti-HIV activity when given in short-term monotherapy studies in doses ranging from 1/2 of a milligram up to 30 milligram single doses. The pharmacokinetic properties of Islatrovir are quite favorable. It has very low plasma protein binding. It is metabolized by adenosine deaminase to one inactive metabolite, but the elimination is balanced between ADA-mediated metabolism and renal excretion. It is not a substrate of any of the major renal transport proteins, nor is it a substrate of any of the major human cytochrome P450s. Indeed, it is not a cytochrome P450 inhibitor or inducer, nor an inhibitor of transport proteins, meaning it has a very low drug-drug interaction potential. Now, the clinical pharmacokinetics of Islatrovir support long-acting administration. The drug is rapidly converted to its active metabolite, the Islatrovir triphosphate. It undergoes very rapid absorption when given orally, without effect of a high-fat meal. And the pharmacokinetics are dose proportional over the range from 0.25 milligrams to 400 milligrams. The parent drug has a half-life of about 50 to 60 hours in the plasma, but the triphosphate, which is the active metabolite, has a half-life of nearly 200 hours, which explains in large part the ability of this drug to exert its antiretroviral effect for quite a long period of time after dosing. Now, Islatrovir triphosphate exhibits approximately linear dose proportionality when the dose is increased. And this is a study that was presented this year at the CROI conference, looking at the concentrations of Islatrovir triphosphate in HIV seronegative volunteers when the drug was given once every 4 weeks over a period of 6 months. And the modeling exercise in the blue and the orange shows that whether the dose is 60 milligrams once a month or 120 milligrams once a month, the concentrations of Islatrovir triphosphate are expected to remain far above the target of 0.05 picomoles per 10 to the 6th peripheral blood mononuclear cells. And these once monthly oral doses of Islatrovir are currently in development for PrEP. As I said before, Islatrovir has a low potential for drug-drug interactions. It's not expected to have DDIs caused by major drug metabolizing enzymes or transporters based on in vitro assessments. It does not inhibit cytochrome P450s, nor does it inhibit glucuronosyl transferase enzymes like UGT1A1, nor does it inhibit drug transport proteins. It is a substrate of BCRP, but the breast cancer resistance protein, a drug transporter, but that's not expected to be of clinical significance given the history with that transporter. Phase 1 studies have been completed now that show no clinically meaningful drug-drug interactions between Islatrovir and doravirine, tenofovir disoproxyl fumarate, dolutegravir, or the NNRTI MK8507, which we'll talk about a little bit later. It also has no clinically meaningful drug-drug interactions with oral contraceptives, or with antacids. The suitability of Islatrovir for implant technology has led to its development for this unique drug delivery platform for HIV. So the drug delivery platform for the Islatrovir implant is the same as that which is being used for the Nexplanon etonogestrel hormonal contraceptive. This is an implant that is widely used globally, and it's a technology that's been around for quite some time. The pharmacokinetics of the Islatrovir implant are illustrated in this figure from a presentation given by Randy Matthews at this year's CROI, showing that in 3 different dosages, 48 milligrams, 52 milligrams, or 56 milligrams, the Islatrovir implant produced triphosphate concentrations above the target of 0.05 picomoles per million cells throughout the entire 12-week duration of implantation in HIV seronegative volunteers. And when the implant was removed at week 12, the triphosphate decayed at the rate that would be expected after oral administration of the drug, indicating that there is no residual reservoir of Islatrovir after the implant is removed. This modeling data takes that 12-week pharmacokinetic data I just showed you with Islatrovir triphosphate concentrations in peripheral blood mononuclear cells for 12 weeks and projects what would happen if the implant were to remain in place for 52 weeks, a full year. And what you can see in this figure is that in a population, the range of Islatrovir triphosphate concentrations would be predicted to remain above that pharmacokinetic threshold for at least 1 year. And so the high dose implant, 56 milligrams, is projected to protect against HIV in the PrEP setting for 1 year or longer. And it could be paired with other agents for treatment. Now we're going to move from NRTTIs to NNRTIs, non-nucleoside reverse transcriptase inhibitors. And we're going to talk first about doravirine. Doravirine has been recently approved at a dose of 100 milligrams orally once per day. It's rapidly absorbed, can be administered without regard to food, and its plasma concentrations decline in a single exponential with an apparent half-life of 12 to 19 hours, supporting once daily administration. Doravirine primarily undergoes oxidative metabolism by cytochrome P453A4, and studies have shown that there are no clinically significant effects of age, sex, race, ethnicity, mild to severe renal impairment, or moderate hepatic impairment on the pharmacokinetics of this drug. Doravirine also has a low potential for drug-drug interactions. It is not likely to have an effect on drugs metabolized by cytochrome P450 enzymes, nor does it inhibit major renal or hepatic transporters, nor is it an inducer of those transporters. However, because it is a cytochrome P453A4 substrate, co-administration with a 3A4 inducer can adversely decrease doravirine plasma concentrations, and co-administration with 3A4 inhibitors could increase the plasma concentrations. Therefore, doravirine is contraindicated with strong cytochrome P450 inducers like rifampin or St. John's wort. In addition, its use with efavirenz, atravirine, or nevirapine is not recommended because those drugs are cytochrome P450 inducers. And when co-administering with rifabutin, the recommendation is to increase the doravirine dose to 100 milligrams twice daily. Now we'll move from doravirine to a new non-nucleoside reverse transcriptase inhibitor, MK8507. MK-8507 is a novel NNRTI in clinical development for HIV treatment, partnered with other effective antivirals. Preclinical data indicate that it has a favorable safety profile, a high antiviral potency, and it retains activity against common NNRTI resistance-associated mutations. Single and multiple ascending dose clinical trials of MK-8507 show that the drug is generally well tolerated when given up to 1,200 milligrams a day, and its pharmacokinetics support once-weekly oral administration. Drug-drug interaction potential assessment is underway, but to date, its phase 1 studies have shown no meaningful interactions with Islatrovir, oral contraceptives, or midazolam, suggesting low drug interaction potential. So these are data showing the anti-HIV activity of MK-8507 in single-dose monotherapy studies in which the drug was given at a dose of 40, 80, or 600 milligrams to HIV-infected volunteers. And in this phase 1b study, these single doses of MK-8507 all achieved the 7-day HIV viral load reduction target with greater than 99% posterior probability, suggesting a high likelihood of anti-HIV activity in each of these at each of these dose levels. Now, as I said before, MK-8507 has a similar resistance profile to ravarine, and in fact is superior to efavirenz against NNRTI resistance-associated clinical variants. And so this figure shows the fold change in IC50 as compared to control for viruses with a virus panel with a variety of NNRTI-associated resistance mutations, showing that MK-8507 and ravarine share similar resistance-associated mutations, specifically the Y188L mutation and combinations of mutations, but does not share resistance-associated mutations to a great extent with rilpivirine or with efavirenz. This slide shows the pharmacokinetic profile of MK-8507 when given as a single oral dose to HIV seronegative volunteers. On the left-hand side is the 24-hour concentration time profile. On the right-hand side is the 14-day concentration time profile. And what you can see in this study is that all doses of MK-8507 greater than 100 milligrams achieved the target antiretroviral concentration for at least 7 days. The terminal elimination half-life of this drug is 58 to 84 hours with a Tmax of 2 to 7 hours, and minimal accumulation is expected with once weekly dosing. As I said before, there's little effect of food on MK-8507, and that's shown on the left-hand side of this figure. And in addition, MK-8507 had no significant impact on the pharmacokinetics of midazolam, a cytochrome P450 3A4 substrate, indicating no clinically meaningful cytochrome P450 3A4 inhibition. Now, because MK-8507 can be given once a week orally, and Islatrovir can be given once a week orally, and because these two drugs do not share overlapping resistance, they are being developed as a two-drug, once weekly oral regimen for HIV treatment. This figure, which was presented at CROI in March of this year, shows the predicted forgiveness of a 20 milligram dose of Islatrovir when given orally once per week. and showing that even if the drug is not taken for 14 days after a 20 milligram dose, the range of islatravir triphosphate concentrations still greatly exceeds the inhibitory quotient for both the wild type virus and for drug-resistant virus harboring the M184V mutation, which is the major drug resistance mutation for islatravir. As a consequence, islatravir at the dose of 20 milligrams once weekly is now in clinical development as in phase 2 treatment regimens combined with MK-8507 at doses of 100, 200, or 400 milligrams. I'm going to finish with another new NNRTI, Lsulfatherine. This is a drug that's been in clinical development for quite some time. It originally came from Roche. It's now being developed by a small biotech company in San Diego called Viriam. The phase 2 results of this study have been presented at CROI in 2017. It has a plasma half-life of about 8 days, supporting once weekly oral dosing. And in addition, long-acting subcutaneous formulations are in development. In this phase 2 study presented at CROI, Lpida or Lsulfatherine was given at a dose of 20 milligrams once a day and compared to ephedrine's 600 milligrams once a day. And more patients in the Lsulfatherine arm achieved a viral load of greater than 50 copies at week 48 than in the ephedrine's arm. However, the figure is somewhat misleading because the percent of viral suppression figure begins at 70 or 60% rather than 0%, and tops out at 82 or 80%, exaggerating the difference between those two arms. So I think it's fair to say the activity is comparable or better than ephedrine's when given once a day. However, Lsulfatherine was much better tolerated than ephedrine's in these studies, showing significantly fewer CNS side effects, such as dizziness, insomnia, or unusual dreams. This drug has actually been approved for clinical use in Russia. That's the only country in the world where it is currently available. But it does have some interesting pharmacokinetic properties that may lead to its being developed and partnered with other antiretrovirals. So in summary, several new HIV reverse transcriptase inhibitors have been recently approved or are in clinical development. New generation RTIs build on the success of previous generations of RTIs. For example, their high anti-HIV efficacy and their barrier to resistance, while improving on tolerability and pharmacokinetic properties of the older RTIs. Most of these agents have a low potential for causing drug-drug interactions, and most are suitable for long-acting administration. That includes both oral long-acting delivery, as we heard about for Islatrovir and MK-8507, and parenteral long-acting delivery, as we heard about for Islatrovir. So I'd like to thank those who shared with me some of the unpublished data that I shared with you today, although all of these data have been presented publicly. And I'd also like to acknowledge my funding sources. And for those of you interested in learning more about long-acting drug delivery, I will refer you to the long-acting extended release antiretroviral research resource project, LEAP, and our website is longactinghiv.org. Thank you.